Welcome. Good morning, good afternoon, good evening, wherever you are. Welcome to day 2 of the webinar series. My name is David Schiefelers. I'm the chair of the World Burns Week steering committee, and it's really my pleasure to invite you or to welcome you really to this day 2 of the webinar series. Now, people are still flocking in. I see people are connecting, so give you a little bit of some time to just connect. If we could go to the next slide, Orlando, that'd be great. All right, just to inform you, there are some translations available that are inbuilt in Zoom. Now, the way to do that is to switch on your captions, which is in some other languages that could be subtitles, yeah, which you see at the very top, the bottom right. You need to activate that, click on that, activate translations, then you select your language, or actually first the speaking language, which is English, and then your own language. In this case, it's Spanish, right? So make sure you do that so that if English is not your native language, you are able to follow along with the speakers of today. Now, let us know where you're from in the chat. That's always great to see. We usually have a lot of global participation from all over the place. So just tell us where you're from, your name, and that is already getting the chat started. And as I'm saying this, I see some chats coming in. So welcome to you. Right. So today is day 2 of the webinar series. As you can see here on the screen, it's on preventing burns in children. And this is a part of an entire global webinar series where we have daily webinars in 2 different time zones happening this week. So it's a very exciting lineup that you can see here. And today, a session is going to be moderated by my friend and colleague, Dr. Orlando Flores from Chile, representing FELAC on the World Burns Week Steering Committee, as well as Professor Dr. Mamta Shaw, representing the European Burns Association from the UK. Orlando, over to you.
Thank you very much, David, and welcome everyone to this second day of the World Burns Week 2025. My name is Orlando Flores, and I am from Santiago, Chile. I'm jointly moderating this session with Professor Mamta Shah from the UK, and we have entitled this session Protecting Childhood Future, Changing Minds and Preventing Burns. So this week is much more than simple awareness. It's about action. And today we are going to try to explore how burn prevention in children must evolve from simply informing people about the risks of burns to changing behaviors. So we are going to try to show you why it's important to prevent burns in children, what we can do, and we are going to listen from experts from Chile, Nepal, and Mongolia. So what experiences they have to change behaviors through prevention programs. So we have prepared a wonderful session, and I would like to thank Claudia Murungi from Kenya, that is going to be our first speaker. Carmina Domic from Coaniquem in Chile, who is going to be our second speaker. Dr. Regina Shilpakar from Nepal, who's going to be our third speaker, and Professor Patricia Price from the University of Cardiff as well. There's going to be our fourth speaker. So we're having a powerful session, powerful voices that are going to guide us through preventing burn in children. Please remember that we are going to advance very quickly. If you have any questions, please post that questions in our Q&A bottom in the bottom of the Zoom screen, so we can manage that questions at the end of the session. We are going to aim for a very rich, powerful discussion, so we can deliver a great experience for all of you that are joining us from all over the world to this seminar. So I'm going to introduce then Claudia Murungi. Claudia is a burn survivor and activist working from Nairobi. Claudia.
Hello, everyone. My name is Claudia Murungi. I'm a burn survivor and an activist from Nairobi, Kenya. I'll be sharing my story today about life as a survivor, how it was before, the experience during the fire, and even life after. Just give me a second, kindly. So, I was in a fire when I was very young. I was 13 years old. And at the time, I had gone for a school trip after finishing my primary school education. So it was very, very exciting. It was a gift from my dad. So that was going to be the first out of town trip for us. So I was very, very excited again. I'd never been out of town. I'd never slept out of home. So I was feeling like I've now become a big girl and I was very, very excited about it. So once we got there, it was just a normal trip. Everything was fine until we got to now the hotel where we were staying at. At the hotel, there was a food warmer. So we were queuing for dinner and there was an open flame. So once I saw the chef was trying to fuel the food warmer, I didn't think anything about it. I mean, I saw some fire, but I didn't think anything about it. I just thought it's normal. This is professional. He's done this 1,000 times before. So for me, I was very confident. I didn't think of it as a dangerous situation. I felt no need to panic. So now, however, though, when he was continuing to fuel it, it accidentally caught fire. And unfortunately, because I was among the first people in line, I was very, very close to him. The fire spilled on my face. It was the liquid. So the liquid spilled on my face, it spilled on my forehead, on my eyes, on my ears. And then actually, as we can see, that was literally the beginning of everything. It was the beginning of my new life. At the moment, I remember I was like, that was I think the slowest 2 minutes of my life. Everything was moving in slow motion. I could feel the heat. But it felt surreal. I didn't believe I was actually on fire. And I think if I had seen it even on video or something, I'd probably have gotten in shock or something. So immediately after, luckily there were teachers around, and the teacher he poured water on my face and was rushed to the local ER. So there, the local ER, they did some first aid, and after the first aid, I spent the night there for observation. So the doctors monitored me, and then in the morning they decided I'm going to fly back now to Nairobi for specialized care. And from then I met a plastic surgeon. I met a guidance and counselor. My parents were also waiting for me in Nairobi. And so from then, that's when, so slowly, I'm noticing things are changing. I'm noticing, okay, how my classmates were acting, how my teachers were also acting. The fact that I had to be flown to Nairobi, I went to Kisumu through bus, but then I'm flying back to Nairobi. So if this was just a normal accident, all this wouldn't have had to happen. So I also started taking mental notes of what is happening, how people treating me. So even before my parents were allowed to see me, they were told they had to go and see a counselor. They had to talk to somebody to tell them not to be so shocked or so surprised when they see me, because if I could read it in their faces, then I'd probably worry a bit more and I'd become more anxious. So once that happened, my parents came in, and eventually after some counseling, after they received their first counseling, they came in and they saw me in Nairobi. And I was able to see now a plastic surgeon who we did a bunch of surgeries. We did continuous plastic surgeries on my face. I had keloids and they treated them and they tried to make them as small as possible. They tried to make my face go back to as normal as possible. So within 6 months, we were done. But then by the time we were done, I remember the surgeon, he told me, Claudia, this is our last session. And I felt very empty. I felt like I was left floating in space. Like, okay, we're done. We've been talking to you. You've been asking me how I am. But I've never, like, what am I going to do now? Because I was seeing the doctor every Monday. So now that's when he recommended for me to see a counselor. And the counselor was able to talk to me and it was a bit better. She started telling me, the first thing she told me was that my life has definitely changed. Things are different now. Like, I am still beautiful, but I also need to mentally tell myself that my life has changed and that things are going to be different. I need to now approach life from a different point of view. So at that point, my parents also decided to switch my schools. So I could sort of have a new beginning. So I could also not feel the pressure of my former classmates coming to see how does Claudia look now? She looks a bit different. And so after changing schools, things were a bit easier, although I really recluded back into myself. I didn't have such a high self-esteem. I was very, very triggered by even the smallest conversation. And children are bullies. So for me, I struggled a bit, especially the first 1 year. And then the second year, I also struggled a lot. But it got to a point where I decided, really, this can't keep happening. I was such a young age. How could I allow myself to continue to be sad forever? I wasn't okay. I wasn't happy with it. So physically, I was healing. Physically, everything was magnificent. The surgeon was saying, I'm healing well. I'm having a good diet. I'm hydrating. I'm eating the fruits. So physically, I was fine. But emotionally and mentally, I was alone for a bit. But then that's when so even my grades started failing. So I had to tell my dad, I had to tell him, hey Papa, like something is wrong. I'm not fine in school. I feel I don't have friends. I'm afraid of talking to people. And after that, so that's when we now decided to get another counselor in school. And the counselor, she talked to me. She told me that things would be fine, that I'd be okay, and not to worry so much. But I also had to also now do something practical about it. I had to get out of my mind, for lack of a better word. I had to stop thinking about it so much. I had to find other things to sort of make a priority. So I started joining clubs. I also joined the local church group, the Christian Union. And after that, things started getting better. When I was in Form 3, there was a new girl who was in Form 1, and she joined, and she was also very, very insecure. I remember when I joined at some point, I had to wear a headscarf because I was very insecure. I didn't want people to see me. I just wanted to disappear. I didn't want to be noticed. I'd forgotten myself, for lack of a better word. So after a while now, once I joined the communities, the Christian community was very, very supportful. The church group, the Christian Union. Also, I joined Scouts, I joined Rangers, I joined, I think, Home Science Club, where we'd learn how to cook also, because I'd also been really, really terrified by fire after my accident, to the point where I couldn't even go into the kitchen. But after that, after finishing high school, I think I sort of, I got out of my head. I created things to look forward to. I created other things that were not just my face. I worked on my personality. I worked on my talents. I worked on my skills, and also religiously. So that really, really helped. So by the time I finished now, again, initially I'd always wanted to go into modeling. And for a point in time, I had forgotten that dream. I told myself, okay, you can't do this. I'm going to go into sciences or something that does not really require you to be physically there. But deep down, I still had my personality. I was still very, very outgoing. I still wanted to express myself through my dressing. So I started slowly. I started with, I joined uni, and in university, I started with my friends. I had friends who had cameras, and we'd do small photo shoots. And with time, I gained traction. I started having deals with organizations. I started having deals with fashion designers, and they would choose me specifically and intentionally because I had scars. They said that was what was unique about me. So I started seeing my scars as my strength. I didn't feel secluded by them. If anything, I felt like my scars made me stand out, as compared to if I had not had scars, I'd still be a model, most likely, but I wouldn't be the model I am in this unique way. So I got a chance to be a model, not just physically, not just for clothes, but also for burn survivors. So now I think I try my best every day to be an advocate for burn survivors. And I think the 13-year-old me, what I had wanted. If somebody is now in a fire at 13, I want them to look and see, okay, when you go to Google, you can see there's a girl called Claudia. There's somebody who went through the exact same thing that I'm going through, and she made it out. She was able to overcome the challenges, and now I'm actually thriving. So I also want to encourage burn survivors and their families, their relatives, the people closest. Like, first of all, it's okay to seek help. It is really, really okay. Like, and it's health like anything else. It's just like if you're in a car accident, you go for physiotherapy. If you go through an event and if you go through an event and it affects you mentally, seek the mental help. If it affects you physically, seek the physical help. And I'm so, so glad to be a part of Interbands, because I can see even within the last 5 years how much progress we've made in terms of normalizing burns, in terms of desensitizing people, and just making burn survivors feel like, okay, it's just another accident. It's not something you did wrong. It's something that happened to you. It can happen at any age. So again, I really, really encourage people to seek help, seek community, and try and be your brother's keeper. When you see somebody who's been through something like that and they're trying to shy away, talk to them, guide them onto counseling, show them that life can be normal and that life can, it can continue. So thank you so much, everyone. Yes, I'm Claudia again from Nairobi.
Thank you very much, Claudia. That was truly inspirational. Your study just reminds us why prevention must be personal, practical, persistent. And I think that sharing your personal experiences with us help us to provide some context to the importance of running burn prevention campaigns in children. So from the personal testimonial from Claudia, we are moving now to three experts that are going to show experiences with us. First panelist is Mrs. Carmina Domic. Carmina is Director of Outreach at Coaniquem, an NGO from Chile. She leads Coaniquem's burn prevention programs and she is a regional voice in burn epidemiology and education. Carmina will share now Coaniquem experience in designing child-focused campaigns to prevent burns. Carmina, the floor is yours. Thank you very much for being here with us.
Okay. Thank you very much. Wait me a minute, please. It's really difficult to talk after Claudia. Wait me a minute. I have problem with the share. Are you looking? No,
Perfectly okay.
it's in the English. I'm so sorry. Okay, wait. Hello to everyone. Thank you for the kind introduction. It is an honor to be here today and share some of our work in Chile at the Corporación de Ayuda al Niño Quemado, known as Coaniquem, a non-profit organization dedicated to the comprehensive care and rehabilitation of children with burn injuries, and dedicated also to prevent these injuries and to do teaching and research in the specialty. Over the next few minutes, I would like to talk about what is important to consider designing burn prevention programs for children and what we have learned along the way. The first step in any effective prevention program is to understand the local reality, the specific context of the community we want to reach. We need to know how burns occur in that population, who is affected, at what age, under what circumstances, and within which environmental and social conditions.
Sorry, Carmina, could
Yes?
you please click Permitir in your screen? Because there's some pop-up window that is perfect. Thank you very much.
So sorry. I continue. Okay, I'm talking to you about that means understanding the epidemiology of burns in children, the geographic and climatic context, the living conditions and home environments, and importantly, the cultural habits and daily practices that shape the risk. This deep understanding doesn't come from a single source. There are different ways to obtain this information, and we must add them up. First and foremost is the one we find in the clinical records of patients who consult of burns. Then there is the evidence available in publications, and no less important is what direct contact with the community bring us. In relation to data need, it's important to mention that it isn't enough to measure at a moment in time. The burns evolution in a population is dynamic, not only their numbers, but also in the way the burns occur. In the slide, we can see the image of a 10-year comparative carried out by Coaniquem about the epidemiological characteristic of our consultants and their evolution over time. The results show that collecting data at one point in time is not enough. As living conditions and technologies change, so do the causes of burn injuries. For example, the introduction of new heating devices or cooking method can create emerging risk if people are not adequately informed about their safe use. This constant evolution reminds us that prevention must also adapt and evolve. Once we understand the local context, the next challenge is to choose our priorities, to define the specific group we want to reach and the behaviors we want to change. We cannot address every problem at once. Instead, we must focus our efforts strategically and move forward step by step. It is also essential to recognize the unique characteristics of each audience. If our messages are not aligned with their values, language, and way of life, we lose the chance to truly connect. I would like to insist with some examples on the importance of identify aspects of our target audience, since otherwise our messages will not be received as their own, and we will not achieve what we are looking for. Climatic characteristics largely determine the causes of burns and the causal agents, as we see in the images. In cold climates, burns are often caused by scalds or contact with heating devices. In contrast, in warm climates, more injuries occur at outdoor. Age is another important factor. Young children are typically injured at home, often in the kitchen or bathroom, while adolescents are more exposed to burns through risky behaviors or work activities. And perhaps the most complex layer of all is that the cultural customs and traditions, how the families cook, heat their homes, or celebrate with fire, are powerful determinants of risk. These are often the most difficult to modify, yet they are essential to understand if we want our interventions to succeed. If I could offer one piece of advice, it would be this: choose your battle wisely and select your tools accordingly. For example, if your target group has access to technology, use social media campaigns and on-the-ground education. If not, focus on community-based education and face-to-face outreach. Always tailor your materials to your audience. Use playful and visual materials for small children and let peers communicate with peers when addressing adolescent and native people. Research consistently shows that multiple coordinated interventions in the same community are more effective than isolated actions target different groups. So, our efforts should be aimed at addressing the same people in different ways, rather than isolated actions in different audiences. Finally, and in conclusion, I'm going to mention 3 points that guide us to continue moving forward. First, improve clinical data systems so that information about the causes of burns in patients can meaningfully inform prevention strategies. Second, with the analysis obtained from the information in the previous point, we have to work in strengthened collaboration with other sectors, the state, legislators, educational system, policymakers, and others, to address the broader social determinants of burns. And third, we need to find ways to systematically evaluate the impact of our intervention and programs, using qualitative and quantitative methods so we can understand what truly works and where we need to improve. Well, thank you very much for your attention. If you want to contact us, please feel free to write to my email or my WhatsApp. Thank you.
Thank you very much, Carmina, for that very systematic approach to burn prevention in children. It shows us that what pays off in this sort of matter is the persistent, is the systematic work, is the way you design your strategies, and that is a very lovely work that Koenigem has been doing for a long time. We're going to move now to our next speaker. I'm going to introduce you, Dr. Regina Chilpakar from Nepal. Regina is a Deputy Medical Director for Sushma Koirala Memorial Hospital in Nepal. She is also working with interburns. And my understanding is that you are now joining us from Singapore, isn't it, Regina?
Yeah.
So welcome to this session, and thank you very much for sharing your knowledge with us.
Namaste. I'm Regina, and today I'm very delighted to share my experience and how in Nepal we empowered community in an attempt to prevent burn in children. Just like Carmina explained, like it is so important to understand the behavior of community and strategically develop our programs so that it actually works. A little bit about the statistics in Nepal. In 2008, Nepal government estimated that about 55,000 people sustained burn injuries and about 2,100 people die. And out of that, third most common injury is the burn is the third most common cause of injury and disability in Nepal. And what we've noticed over the years, in my experience and my colleagues' experience, is children coming from rural areas, they have sustained more severe burns. It is also the second most common cause of unintentional injury in children below 5 in Midwestern Nepal. The causes, like in every other marginalized and middle income countries, children get burned by hot water when they're playing around the unsafe environment of the kitchen. And we also had many patients who've arrived. The mother is carrying the child while cooking, and the child has actually actually fell down in a big pot of porridge or in a large pot of hot boiling oil, a large pot of milk. So it also shows that there is a lack of awareness of general health literacy among the mothers and the primary caregivers. A lot of children get burned because of the ground level open fires and LPG gas accidents, kerosene stoves, and because of mismanaged electrical wires in our villages, town planning, cities, and also contact burn and chemical burn, but the most common is scald and flame burn. These two pictures of the patients that we treated in my facility, Sushma Koirala Memorial Hospital, it is actually the representation of all the things that went wrong in the safety of children. The first kid that you can see, he actually went to jungle to collect the fodder, and he was playing with matchstick. So he sustained a flame burn injury. His parents thought he was going to die anyway, so he was not taken anywhere within 2 weeks, and the child survived. So they started looking for help, and then when it came in social media, we saw the case and we called the child for treatment. And another kid is an example of many young boys, especially. They also go for cattle grazing in forest, in jungle, and he accidentally got in touch with high tension wire, which was actually installed by the villagers themselves to ward off animals. So this shows that these children were exposed to completely unfriendly environment, and they were given the completely child unfriendly task. They had to do those activities. This is also because of the lack of awareness of prevention. And when the parents the child sustains injury, the parents don't know what to do, especially in the rural areas, and they they bring the child late to the facility, and by the time the child will have already sustained very severe injury, and it is too late to sometimes salvage the limb, salvage the life, and even if the child lives with a long-term disability and many more surgeries to go ahead. Small statistics from the facility I work in of 5 years, we can see that out of total number of patients, like even half, like 50% is 45%, 43% are children. In the gender distribution, males seem to be slightly higher. And among the most common cause, skull burn and flame burn are the highest. And children coming inside, from inside and outside Kathmandu, they're pretty much the same, but what we realized were children sustained severe burn injuries who came from outside Kathmandu. So we thought, out of all these problems, prevention is the main treatment. Prevention is the cornerstone to tackle these problems. There are many stakeholders at different levels who are important. So we decided to work at the grassroots level to prevent burns in children and the sequelae, what we can see in this picture, what happened to this child. So in 2017, Interburns partnered with Sagun, a local NGO which was supported and funded by National Institute of Health and Care Research. And we chose 3 municipalities. Actually, this whole process was in detail presented by our colleague, Dr. Kamal Fial, in the session previously. So I will say in short, survey of 1,279 households were done, and we found out that most of the accidents happen at homes, in the domestic settings, in kitchen, and mostly women and children are getting affected by it. So this project was started with participatory action research involving local leaders, female community health volunteers, burn survivors, and so many ideas from them were taken for data collection, how we can develop a safe environment for children and how to prevent it, how to train people. So after the survey, a package was developed according to the suggestions of the local leaders and the female community health workers and also the health personnel who work in the health posts in the community. And after we develop basic burn care package and community burn prevention package. So within 2 years, we trained 65 primary health workers, 115 female community health volunteers, and 800 plus women's cooperative members and school children. And they were trained in a way with visuals, with discussions, with demonstrations, with posters, and with the magazines, with calendars that show the cartoons which they can relate to. You can see the photo, the women in wonderful blue saris. They are the female community health workers, and they are the strong and the grassroots. They have the robust network that get in touch with mothers and each household in their ward and in their community. So we thought they were the most powerful group to be in contact with, who can relay those education to the mothers. So we empowered the female community health volunteers that they should hold monthly meetings, and they should always speak about and discuss about burn prevention. And what we teach them, they should teach these safety tips during their whole home visits, and encourage neighbors that these safeties should not only be a task or a duty, it should be the way of life. And we distributed burn bulletin calendars, flip charts, and posters to them to be distributed among the children, to be distributed among the mothers and the primary caregivers, because they are the ones who the households in the rural areas really do trust, even for the medical and non-medical advices. So these are the posters, and that we distributed these who they can actually relate to. This shows the children how the kitchen is not a safe place, and how they can train the mothers that they should put a barrier, or for example, while cooking, they should not be carrying a child, and that when even small thing like putting the handle inward while they are away and have just cooked a very hot meal, and put the even a cup of tea away, that so that the child cannot pull it. So small changes, we train them to train mothers and the primary caregivers to make a way of life. And after 2020, the impact in our follow-up visit and follow-up survey, we found out that among the three municipalities, in two municipalities, there had no burn injuries sustained, which we previously found out that there had been about 92 cases in all three municipalities. But after 2 years, we found out that two municipalities did not have any burn injury cases. And from this pilot project, we found out and we could learn that if given proper training and orientation, that burn can be prevented. So we started and expanded this prevention program to school children, to mothers group from different communities. And we started training. We also started getting invitation from ward to ward from the female, especially from the female communities, mothers group. We gave them simple lessons like first aid, how to do it when one gets burned, when people surrounding your area gets burned, to stop, drop, and roll and not panic, and cool the wound first, and not use any other believed first aid modalities like mud and cow dung or aloe vera, toothpaste, tomatoes, which we normally see patients coming in with. So we taught them very few points, but very basic and important points, and then safely transport them to the hospital. After the success of this program, we also made a lot of proposal requests in the different level of the government, and central and the local government helped us and encouraged us to integrate this burn prevention program into rural health plans. So, and government actually helped us to choose the participants from different provinces, all the provinces all over the Nepal. So we do not just focus on one place or just inside Kathmandu. We teach them, we demonstrate them first aid, we teach them how to do simple dressing, bandaging, and for female community health workers, it's more like discussion. We make them participate and get them to answer themselves that how the programs or how these steps can be implemented. So from all this, what we learned was childhood burn can be prevented if taken small steps in a unity manner, and that it should be integrated into a school education system, which is more important than we'll be directly communicating with the children. And we should there will always be burn no matter how much we try to prevent it. So we should train the grassroots level people, the people who are more in contact with community, the prevention, and even if it cannot be prevented, at least proper first aid and proper referral system, how to refer in the burn care specialist hospitals. And this picture is actually very special because the person who is giving the orientation to the community health workers were the burn survivor herself, who sustained burn injury as a child, and it was an acid attack. But she was brave enough to come through this, and then helped her, encouraged herself to be part of this pilot program, and she was throughout with us during this pilot project. Conclusion and the lesson learned is childhood burns in Nepal are preventable, but multi-sectoral approach should be done. It is a public health crisis, so public health approach is very essential. Prevention saves lives, it is true. And in case you were wondering, the kid in the first picture covered with the cow dung and mud, what happened to him? This kid is him. We managed to save him and give him proper treatment. He went back to school. Thank you very much.
Thank you very much, Regina. Powerful presentation as well, showing us how burn prevention should be holistic, involving authorities. The importance of the community involved in prevention. That is absolutely amazing. So we are going to move to our next speaker. This talk has been recorded because, unfortunately, Professor Patricia Price is not connected today. Patricia is co-founder of Interburns, leading researcher in global burn policy, and we are going to watch this recorded presentation regarding how changing cooking practice in Mongolia can reduce pediatric burns. So please put play on the video. Thank you.
Hello everyone, I'd like to start by thanking the conference organisers for inviting me to be part of this symposium and to apologise for not being able to do this as a live session. We need to acknowledge a number of people who are part of the project, not least the participants. You will see some photographs in the presentation, and I want to assure you that everyone's given permission for that to happen. We did receive some funding from the NIHR in the UK. And technical support was provided by Kathy Miller Studios in providing some of the technical drawings. The biggest thanks, though, has to go to Gerelmar, who is the first author on the publications related to this study, which I'll share with you later on. At the time of the study, she was a PhD candidate, but because she was from Mongolia and spoke the language, she was an enormous help because she knew the context, she knew cultural practices, she knew the importance of traditional methods of cooking, and allowed us to make a wide network of collaborations, partners that allowed the project to be such a success. A bit of background for you. Mongolia is classified as an Eastern European or a Central Asian middle income country with a population of about 3 million. Now, this study took place in the capital where about 50% of the population are based. But there's something particular to Mongolia that led us to want to be involved. A study in 2013 showed that there were about 8.1 per 100,000 children involved in a burn of injury of some sort. Now, when you take it that the mean for all the other countries classified in this group was 1.3, this really stands out. And you can see on a colour coding that Mongolia here is the darkest colour, and it really does focus attention on asking some questions about what is happening here, what is different. Many people in Mongolia live in what we would call Mongolian yurts, but locally are known as gers. These reflect the traditional nomadic style of many people who live in Mongolia. But the thing that's really important from this study's perspective is that there's one living space. Everything happens in this one space. There is no separate cooking area, and everything takes place here. And the majority of traditional cooking happens in what's known as a cooking pot. You can see a picture of a modern cooking pot in the far corner and a lady using it on the floor in the middle of the ger. And even when they're electric, you can see there are often wires across the floors because somebody's literally sleeping in this bed above it. Everything happens in this one space. So this led us to ask a number of questions around whether we could design a practical but culturally acceptable solution to helping to remove some of the risks. Bearing in mind, it's not practical to find a separate space, and the cooking pot is an enormously valuable traditional method of cooking here. The study design that we used involved 50 families that were randomly selected with the help of the local council officials. They had to have a young child living there, be living in a ger and using the cooking pot, obviously, to be part of the study. Now, what we designed, and that did take a lot of background work, was a steel rack that would elevate that pot off the floor. And we provided these free of charge, 75 centimetres high. You can see in some pictures that I'm going to show you how they were used in practice. There was a lower space for storage, so it should fit reasonably well within the size of a ger. We worked with a local set of researchers and trained them to be able to show each family how to use the ger and how to collect the information that we were interested in terms of how we could then evaluate their use of it after both 30 days and then again 10 months later. These are some photographs of some of the families and show you how they were using the gear. In this particular photograph, you can see they've used the rods to keep the pot quite firmly in the centre of the rack, near the two central poles. This particular family divided that top section into a smaller pot, but it allowed them to use the kettle in the same way. This family has put it against the side of the gear, against one of the walls. Now, after 30 days, the person who was responsible for cooking, which was usually the mother, but often was the grandparent, or very occasionally an aunt, was asked to complete a paper-based structured questionnaire, which we had previously obviously developed and piloted. In addition, we asked them to attend focus groups in either local community halls or some equivalent sort of space. The largest number attending was 10. After 10 months of continued use, we then asked the researchers to individually visit each household in order to complete a semi-structured interview. And in both of these instances, the emphasis was on their experience of the rack, things that they thought we could do to improve the rack and make it even more acceptable, and how much they might be willing to pay in order to have such a rack in their household. These are some pictures of the focus groups taking place. This one was in the local library, this one was in a local community hall. For those interested in the technical details, we used R version 3.4.2 for our analysis. There was a qualitative stream of data analysis, which we used with multiple researchers analysing the data on an iterative process, confirming, collaborating in terms of their understanding. Also quantitative methods, particularly for the willingness to pay and trying to rank their preferences for the improvements they'd like to see. And for that, we used the best-worst scaling method in order to give them some ranked priorities. Some details on the participants. You will see from this slide that most of the household had 2 children, but here is the range, an even split between male and females, a number of cohabitants, and then again their income. And we used this to be able to look at whether or not income related to how much people were willing to pay. You need to be aware that 100,000 of the Mongolian Turgorets are equivalent to about $35. This was a particularly motivated group because of the 50 households, 40 of those households actually reported having a child who had been burnt in previous years, including some that were sufficiently seriously injured that they needed to be in an inpatient. The qualitative data is obviously quite dense, but here's some of the top line messages. And you will see from that most of them felt it was an extremely positive outcome. They liked the design. They found that visitors were very interested in it. Where did it come from? How much did it cost? But generally very positive about the fact that they felt it made a difference in terms of risk to children, but also in terms of how they were able to manage childcare and not have to spend quite so much time constantly warning the children to avoid the pot. There were some design features that they requested we thought about, all of which were quite sensible, that we then used in the later follow-up for them to prioritise. So all in all, they actually thought that it was a good thing. Things like rounded corners, very sensible, wider feet, covering the lower rack were all ideas that we were willing to take on board. In terms of how much they were willing to pay, the average here at the top equated to about 37 American dollars. And that stayed pretty stable both now and later. We've split it here between their incomes, between whether or not they'd had a child who'd been involved. they weren't significantly different, although again, how much you earned did influence whether or not you were willing to pay a bit more. 10 months later, we went back and asked them for their long-term evaluation. Now, 6 families had stopped using the stove, and that's worth bearing in mind, because they had changed to using a winter stove, which is central to the care. And there were unfortunately 2 burns reported, although the rack wasn't involved in either of them. And one of these was unfortunately very serious. In this case, they had returned to using the pot on the floor, and it certainly brings up the question of how you maintain the long-term behaviour change and long-term support that might be required. One of them had actually had an accident involving the stove itself. As I noted earlier, the willingness to pay actually was pretty stable. The modifications that they were particularly interested in was the enclosure of the lower section, and we certainly agreed with that. In some instances, the children had used them to put their toys into the lower section or try to climb into it, so that was definitely thought to be a good idea. And they wanted an opening in the top section where the flex could more easily sit and link to a PowerPoint. And of course, rounded corners, and anyone who's been a parent knows how important that is. We also then showed them the design of what it would now look like if we took all of their comments on board, and this is the final design that we came up with. The focus group comments, again, remain very similar. Loved the rack, thought it was very beneficial, but they did pick up on the fact that ongoing support would be very useful, so that in any rollout we might allow that to become part of the programme. One thing that was an omission on our part is we didn't stress strongly enough that the rack would not get hot if it was placed next to the winter stove, which was the reason why the families in some instances had chosen not to use the rack over the winter. The rack actually stays at the same temperature all year round. What was interesting, though, was the visitors over that 10-month period had again asked questions about where could you buy one, how much did it cost, and again had noted the change in parental behaviour with that safety element. So, lessons learnt. It's a relatively small change in some instances, but it seemed to have a big effect. So even small changes, though, do need a lot of preparatory work, and the need for local knowledge and cultural sensitivity cannot be stressed enough. It took us several goes at a prototype, and we certainly needed a local team to conduct the work. And unfortunately for us, COVID hit during this project, which meant that all of the study was completed remotely. We were not able to visit during this time, but it shows things can work. Now, to get this to be rolled out, we need a government or health policy change, and that's going to be much harder for us to work on and help to happen. Here are the 2 publications. Both of them are in Burns, volume 48, if you'd like to look those up and find out some more details. So thank you for your attention. Small changes can work, but it takes a lot of motivation and take a lot of enthusiasm. As we say in Interburns, let's go on and make it happen, because tomorrow is too late. Thank you.
Thank you. Just checking. I think that there's no questions posed in the Q&A. So if you wanna, there we have the result of the poll for you to consider for the closing remarks, Mamta. Most of the people believe that all the options above, both cultural beliefs, access to healthcare and first knowledge, advice from trusted community figures, exposure to media and public campaigns, are having influence on caregiver behavior in preventing burns in children. That is something that all the respondents has. So I'm going to share the screen for the closing remarks.
Orlando, do you want to go to the second poll question, because we still have a few minutes left? So we could run through the 4 polls because it's important for participation. Thanks very much.
Okay, David, it is possible to post the second. There you go. If you would like to participate in this Second question as well, which factor do you believe is the more effective in families adopting safer home practice? The perceived risk of burn injuries, the cost of availability of the safety equipment, the influence of a school or daycare education, the support from the local health workers, or none of the above? What do you think will be more effective in families adopting safer home practices? We're going to give you a couple of minutes to answer that question again. And David, please, when you have the results, please put it in the screen so we can use that information for the closing remarks. Please remember that you can always put your questions in the Q&A bottom in the Zoom screen as well. There's a Q&A. There you go. So the result of the poll, most of you believe that the perceived risk of burn injuries is the factor that more effectively influence families for adopting safer home practices. So probably we should work also in education for increasing the awareness of risk for burn injuries. Yeah, so we don't have at the moment, Mamta, any questions in the Q&A.
There are three more. There are two more questions.
Oh, we are just.
Yeah, we'll go through all four. We'll go through all four.
Do you want to take the other ones as well?
Yes, please.
Okay.
There is enough time for the questions. It's a good interaction. Thank you.
So there's question 3, community engagement. What motivates communities to participate in burn prevention initiatives, in your opinion? The personal experience with burn injuries, the leadership from local champions of burn survivors, the incentives of recognition from institutions, the integration with broader health campaigns, none of the above. What do you think it motivates communities to participate? This is all information that we are going to use in the future. So thank you very much for participating. When you have results, David, please share it in the screen so we can have a look and then prepare the 4th question as well. There you go. So this is more balanced. So what motivates communities to participate in burn prevention initiatives? Almost half of you believe that personal experience with burn injuries, and the other half is thinking that leadership from local champions of burn survivors. Those are the most voted options. So this is very, very interesting. Are you taking notes, Mamta?
Yes.
Yeah, lovely. Last question, please, David. There you go. So the last question, which type of message is most effective, in your opinion, in changing behavior to protect children? Do we need to use emotional stories from survivors, simple visual safety instructions, data-driven facts and statistics, messages endorsed by local leaders, all of them, none of them? Please share your answers with us. When we are ready, David, please share with us the results. Okay, there's a very solid 67% saying that all the above is more effective in changing behavior to protect children. So it's going to be sometimes emotional stories, sometimes simple visual safety instructions. Nobody relies on data-driven facts and statistics. That is very hurtful for me, especially. Messages endorsed by local leaders. Well, that is what all of you are choosing. Okay, Mamta, over to you.
Yeah, thanks. If you can do the presentation, please. Right. Everybody, thank you so much for joining us today. And I do hope that it has been very useful. And for me, certainly, it has been a learning experience. Why do we need to change? Why do we need to prevent burns in children? Well, you have heard today, Claudia made a very good case. Protecting childhood futures is very important. Preventing burns protects children's futures. And what is most important is that challenges of burn injury in childhood evolve over time. And it's okay not to be okay and to seek timely support and change a negative experience. You have seen how well Claudia and her colleagues have done, and they have become campaigners in their own right. They're collecting data informs behaviors that lead to burns, and this is largely preventable, as Carmina has mentioned, and as well as Regina. And both Regina and Trish have demonstrated that engaging community, families, it's a multi-professional engagement rather than one person doing it by themselves. You cannot work in silos. Small changes can make big differences. And I think together we can certainly make a difference. From the polls, you have seen that it is not single behavior change. When somebody has experienced, when the community gets involved, when the practices change, and when they're enforced, are things that really help with preventing children. Next slide, please, Orlando. So, as you all know, together we can all prevent burns in children, and it is time to come together and not work in our own silos. Next slide, please. So I would like to thank you all for joining this webinar. Do keep in touch. There are other webinars for the rest of the week. And next slide, please. If you would like a certificate of attendance, please use this QR code, but don't panic. Once you come out of Zoom, there will be another opportunity for you to fill the feedback survey. And once you have filled out the feedback survey, you will be taken to a certificate of attendance form that you can fill in as well. Next slide, please. And please remember, there are still 3 more days. There are 3 more webinars to go through, but there are also lots of opportunities to do your own local activities. As I said, it is important to come together and work together. So let's all try and prevent burns in our communities and organize some local activities. You've got plenty of ideas today, and I do hope that you will be able to engage. Next slide, please. And don't forget, save the date for next year. We are looking forward to having you again. Thanks very much, everybody. And thanks very much to all our speakers and our moderators. Thank you.
Thank you very much. Have a good day. Goodbye.